Good morning, everyone. How are you all doing? Glad to hear it. Well, welcome to St. Louis. Thank you for all of you that traveled from near and far. It's a wonderful city, and we are extremely pleased to host you. I think we're ahead of schedule. Leave it to Dr. Morris to run an extremely tight ship, so I promise not to take too much time, though. Food is the best way to the heart, so a quick aside, if you haven't tried it and are interested in ooey gooey butter cake, Emo's pizza, or barbecue, I can only vouch for two of those. You'll have to figure out which one I'm not too much of a fan of, but you might spike your A1C and take a little hypertension back with you, but it's worth it, I promise. So Andre set this up really quite well because she talked about the language table, which was something that we've been working on for well over 3 years. And so I have been tasked with talking a little bit about that, and it went all the way to the end. There we go. All right. So these are my disclosures of interest, nothing really exciting to disclose. There we go. Okay, so this is going to be unconventional. If you've got a smartphone or a laptop, you can tune out. You don't have to listen to me. But you could check out this link or URL at the bottom, because that's essentially what I'll be talking about. It's free, it's accessible, or if you Google Alzheimer's Association and Inclusive Language Guide, pull it up, bookmark it. It's been a labor of love and something that we'll dive into a bit. So I was tasked to really provide you with not just a resource, but what I hope is going to be helpful and instructive, not just for research, but also for advocacy, for clinical work, and also for practice. As many of you know, language is absolutely critical for communicating not just your work, but also crucial for health disparities and health equity research. A shared lexicon can effectively communicate differences and similarities that shape disease risk, resilience, treatment, and experience. The lack of a shared lexicon can lead to significant issues and miscommunication. So for example, if I say the word sent, and sent, you probably can't distinguish all three of them. And that's because they're homophones. They all sound alike. The first mention of sent was relating to currency. The second mention of scent was relating to olfaction, or odor identification. And the third use of scent was relating to the verb to send, the past participle. Now, granted, that's an example of auditory comprehension and verbal expression. The same exact example can be applied to the written text, the written word. And the other thing I want to share too is that language itself changes over time. And one prominent example of that is the shift from using the label Caucasian to white. You'll find that explicit in the OBM classification in terms of the census. The term Caucasian really originated in the 18th century by a German philosopher and a scientist, and he thought the inhabitants of the Caucasus Mountain region represented the pinnacle of civilization. The term has been adapted, and over centuries it's been used to create this taxonomy that has really poor pseudoscientific origins. So unless a person is from Armenia, Azerbaijan, Georgia, not to state the country, or southern Russia, it's inaccurate to use the term Caucasian to describe somebody who's white. And we won't go into all the specifics about race and ethnicity quite yet. Now, in ADRD research, or Alzheimer's disease and related dementia research, I have to stop using acronyms, we have scientists working at the molecular level all the way to the population level. And that work is absolutely critical. An inclusive language guide is something that did not exist, and it's something that we set out to do back in 2020. And in speaking about 2020, on May 25th, 2020, in my other home in Minneapolis, Minnesota, a very pivotal event occurred. That was the public execution of George Floyd. That also catalyzed a massive movement across the United States in terms of Black Lives Matters. And so in thinking about that, having discussions in the midst of a pandemic, I took the helm of the Diversity and Disparities Professional Interest Area in July of 2020. The professional interest areas, they're one of, I think, almost 30. Somebody will have to correct me if I'm wrong. These are all essentially work groups, part of the Alzheimer's Association and the iStart. We began discussion about a language table, and Maria Carrillo and Dr. Carl Hill said, there's other groups that are quite interested in putting together something that we can all use as researchers. And so in October of 2020, this was really helmed by Andrea Gilmore-Bajkowski and William Hugh. I was thinking about WashU when I abbreviated his name. And so we came up with a one-year plan, the best laid plan. This is something we can knock out in 1 year. Well, fast forward a year later, October 2021, we finally completed the first draft, and we also created an RFI, or a request for information. In May of 2020, the first layer of reviews was completed, and this was using a solicited peer-reviewed panel of experts, who I'll talk about at the end. In July of 2022 at AAIC, just last year, we presented to the conference, and we also opened up the RFI to anyone and everyone who wanted to critique and examine that specific language guide. In October of 2022, so a year ago, we responded to all of those comments, we revised it, and then we finalized the draft for submission in January of this year. We fought with a copy editor, and thankfully I was not at the front with that. Andrea took the brunt of that. But we were finally able to publish that on August 16th of 2023, 3 years later. And so essentially, here's what you have for this language guide. There we go. So there's 7 different sections. The first is just the introduction, why we decided to create this language guide. The second is guiding principles, or 11 tenets that I'll quickly whip through. And then there are 3 specific demarcated sections of that language guide that we really wanted to drill in on. The first is race and ethnicity, that I'll briefly talk about. The second is communicating about geographic and social and economic context and contextual factors. And then the third is communicating about sex, gender, gender identity, and sexual orientation identity, led by my wonderful colleague, Jason Flatt. And then a glossary of terms. But really, the 11 important tenets, or our commandments, were we wanted to focus on total inclusion. We also wanted to not conflate biology with social social constructs. So thinking about race and ethnicity and genetics. We wanted to integrate health disparities and social determinants of health within this language guide. Reduce blaming, stigmatizing, or stereotyping language. Focus on language that respected different groups and different identities, especially since identities can change over time. We also wanted to create a space that if you prefer to self-identify with a particular label, you are able to do that. We also know that language varies by region, context, and across time. And then we also wanted to provide an appropriate level of specificity. And the last 2 is reducing any dehumanizing language, and I'll give 2 examples, and not using abbreviation, because that's what we do in medicine and research. So when thinking about race, this is a good visual acuity test at 8 in the morning for you. I apologize. Like I said, you can read it bigger on your laptop or your computer. So the first recommendation, I think, is really quite important. So these are call-out boxes. There's a ton of texts really discussing the rationale, the research that went into thinking about how do we communicate our science clearly relating to race and ethnicity. So nationally, regionally, or locally specific uniform classification systems use those for collecting and reporting data on race, ethnicity, and other cultural identities, those factors such as nationality. These classification systems may shape other requirements for data reporting and collection and aggregation, but may not be sufficient or specific for all research questions that we want to ask. And a key part of that is the use of the US Census OMB classification. The fact that we still have 5 main categories and an other is really not sufficient. I know 2020 was supposed to include this massive revision, and that really didn't work quite well. And so this is, as a response to that extremely limited grouping, we wanted to build in an additional write-in space. So if you're running studies, have a space for string variables or for folks to writing how they prefer to self-identify. Let's see. In going to, I think, the bottom call-out box, I think avoid using adjectives or nouns that label people, such as, for example, stating blacks or the poor. relatively dehumanizing language, but instead adopt phrases that are more descriptive, like Black older adults, or persons or people living in poverty and people with limited literacy. Again, the recommendations are there. We're hoping that journals, and the Alzheimer's Association family of journals is adopting this, and I believe we're hoping to continue to disseminate this throughout the field. All right. The fifth section, which is looking at geographic and social factors, really was rooted into this massive expansion into health disparities, but also social determinants of health. How many of you have heard about the ADI, another acronym? The Area Deprivation Index. It's really had a significant uptick over the past 3 years. And Dr. Kind and our colleagues at the University of Wisconsin-Madison have done incredible work moving that needle forward to better understanding disparities at the neighborhood level, at the census block level. But when we're thinking about measurements, it's no longer sufficient to use income or ask folks, well, how much do you make approximately, right? It's useless data, and I'm saying that. It's not very helpful. We need to delve beyond and go to the household level to better understand where folks are living. Case in point, if you go 4 blocks west, you go past something called the Del Mar Divide here in St. Louis, you will see significant heterogeneity within one block. You'll see a home that's abandoned, a home that's occupied, and an open field. That level of specificity isn't typically captured by anything that we're currently using in research right now. So when you're focusing on geographic, social, environmental, and contextual factors, think about measurements. Let's see if there's anything else interesting that I wanted to share. Like I said, the URL is there. Please do take a look at it. If you have questions, I'm happy to answer any additional things regarding the evolution, the creation of the evolution of the Inclusive Language Guide. And then the work group members are to the left side of the screen. A lot of you are present here. Thank you again for joining us. And same thing with those that have provided critical feedback and helping to push us so that we are being more inclusive as we created the language guide. Thank you for your time. I appreciate it. Yeah, I'm happy to take any questions.
Questions for Ganesh?
I think we have 2.
I just wanted to know, because language is so dynamic and these terms are so dynamic, what's the plan for updating and making sure that this guide is also dynamic?
So could you repeat the question? You said, what's the plan for ensuring that the language guide is continuing to grow? Mm-hmm. That's fantastic. And actually, that was one of the initial discussions that we had when we started the language guide in 2020. We know language changes over time. And so the association, where's Percy? How are you doing? All right, so Percy's been in those meetings, and the association has reassured us is that every few years, we will convene a group with members that were present in the original working group in addition to new members so that we can take a look at what work has been done, how language is involved, what do we need to do to update it, and then publishing a new revised version. And I think a great hallmark of that is the Alzheimer's Association's Facts and Figures. Every year you get a brand new fact and figures looking at the state of the science relating to Alzheimer's disease and related dementia. So thank you for your question.
Thank you. Excuse me. Thank you for sharing that wonderful work. I was just going to say, in my travels, I noticed in interacting with Afro-Caribbean individuals that, as to her point, creates another level of dynamic understanding that you have to address. And so she hit it right on the head. It's like, how are we going to embrace that level, just within that ethnic group? I don't know.
Another fantastic question. So how are we addressing the heterogeneity within the field? And actually, we had that occur just in March of this year. We were doing community-based system dynamics, which is like participatory action research on steroids, and we had a participant who was from Haiti, and he said, I don't like the term African American. I'm not African American. I'm from Haiti. I'm Haitian. I'm not a Haitian American. And I said, you know what about, and we had a great discourse in terms of what would be quite appropriate. And so he said, well, if I had to choose one between black or African American, I'll choose black. But then I'd also like to be identified by my nationality. Same thing for me. I'm Asian according to the US Census. That means absolutely nothing because I usually do other, which throws everything off. But I'm Guyanese, and that is never on the list of nationalities that come up. But I do hope that we continue to have this conversation, and language certainly evolves so that we're examining all of these social identities, but also the intersectionality among all of them. So this is, I think, just the first step, moving the needle forward in that direction. Yes, so we've got two other questions.
So my question was a little bit along the same lines about how we take the identity when individuals place their identity in other, especially when it's a nationality, and how we incorporate that into analyses where we can do the analyses but also be respectful of what individuals identify as.
That's a $1 million question right there. R1 level question. So it is challenging, right? Because when you're running your analyses to relegate someone into the other identity, you've got an N of 3, right? It's very challenging. And so we did have that discussion too, because you need to be sufficiently powered if you want to detect any meaningful differences. And so the way in which you can group them into other minoritized groups, but I think part of that is going into the limitation section and being quite deliberate in saying that we had a small number. And this is how these participants self-identify, and actually calling attention to it. And by repeatedly doing that, I hope that we can help to shift measurement, particularly in terms of, I know the UDS4 is coming out, right? But influencing significant data collection, national data collection metrics to say, let's figure out ways in which we can harmonize but also normalize those that don't fit really quite well into those bins. Because only then could we truly get to the heart of the matter, which is how do we bridge the gap in terms of health disparities?
Thank you for this terrific work. This is so important. What role or what plans might you have for influencing the editorial boards of our scientific journals?
Ooh. So the question is a good one. So the question is, what plans do we have to potentially influence the editorial board of a journal or journals? And so it's a great question, because you've got the editorial board, but then you also have reviewers, and reviewers come from all walks of life. I review for way too many journals, I think 46 right now, and I don't know what they all are for, but it is challenging depending on what field you're in. So I think a starting point, and this is what we had with Alzheimer's and dementia, is we had a conversation with Dr. Donald Wilcox, who's the editor-in-chief, Dr. Lisa Barnes, who's the deputy editor. They're cognizant of this, and then we're making this available for all of the editorial boards so that they're familiar with the language. And we're saying, review it, understand, and integrate some of this in terms of the journal's requirements for when you're submitting a manuscript. You need to pay attention to use these language. These are the recommendations. But it's also the same thing that we have to do for reviewers. When we're getting the reviewers' comments coming back in, especially if they're from international or outside of the United States, we need to also educate them in terms of the lexicon and what we're using here.
Just as a quick suggestion, I think one thing you might do is reach out, for example, to Joe Auslander at the Journal of American Geriatric Society, because certainly it's had an outside influence in the reviewers in working with the people submitting journals in using words that are not ageist, for example. So I think there's a lot of traction to be had.
Yeah. I mean, it's a big machine, right, when we're thinking about publishing and how do we shift it. But I think it's just a lot of repetition, ensuring that folks are exposed to it, and we're calling it out when we see it. Yeah. Thank you for the great question. Andre, I think you had a question?
I guess it was more of a comment than a question, but one of the great takeaways I thought from reading that was the comment about how like word limits or need for brevity was not an excuse to not use kind of catchphrases, so I don't know if you want to say anything
I-
else about it, but I just, that like
Yeah.
stuck with me as writing things up, that is really important.
So it's a great comment, actually, and one that, for those of you that are publishing, you know the headache, right? You know, if it's you're confined to 3,500 words and you're trying to fit absolutely everything, it's easier to say AA versus African American, or Asian and Pacific Islander, and abbreviating it. And so where we're shifting to is saying, well, listen, we don't want to, shortchange the acronym. Instead, we say persons racialized as Black or as Asian. And that's adding more words to it, but we're hoping that editors would make that exception. And I think part of that will be continually address the importance of recognizing social identities, and ensuring that they're not just giving space for that to occur, but not penalizing those of us that are submitting. So that's a great question. Are there any editors in the room? Take notes.
Hi, Ganesh. It's Allison Lindauer from Oregon Health and
Yes.
Sciences. Hi. And when people ask questions, could they tell us their names and where they're from? And I have a burning question, and I'm not sure where to ask it, so I'm hoping, I know you're a nice person and you'll help me out here. Speaking about publication and talking about the demographics, our team in Oregon, as you could probably guess, Oregon is a very white state, and one of our perpetual challenges is recruiting non-white people to donate their brains after death. And we talked to our neuropathologist about this, and he said that when they send out brain tissue around the world, that not everybody reports on demographics because there are so few brains that are not white, that it's really, for many researchers, they don't need to report that because there's so few. And first, I want to find out from the specialist if you could come to me at the break and tell me that that's not true. And second, is there a requirement in journals for whatever research we do? Isn't there a requirement that you publish demographic information? And I realize that that's a little bit off topic, but if we're talking about nomenclature, isn't that kind of a basic? So thank you for your patience.
Yeah, well, thank you. So Allison's, I think, comment and question is that for brain donation, some groups and actually journals that are publishing indicate that you're not required to necessarily indicate whether the person, what's the race or the ethnicity. And so I'm not in pathology. I don't know if Rick Perrin's here from our group. But I would think that would be the absolute minimum. You have to know where that's coming from. And I know my colleagues from Rush, I know Crystal and Brian, you guys are here. So, and Lisa's done tremendous work in terms of looking at brain donation in the Rush cohort. So they would be the ones to chat with. Sorry to put you on the spot, but I think it's a great point, and something that we need to expand in terms of looking at after death, looking at pathology. Yeah. Tell me if I'm going over time, John.
Justin Miller from the Nevada Exploratory Site in Las Vegas. And I apologize if you've already addressed this in your talk or if it's documented in the guidelines, but could you speak a little bit about how the voice of the participants themselves were incorporated directly in the formulation of these guidelines and in the review of these guidelines after they've been put forth?
Yeah, so that's a great question, Justin. Thank you. So did we incorporate the voices of participants? Did we incorporate the voices of participants in either the drafting of the initial document or the RFI? And I will be honest, I can't recall. Megan, are you here? Megan, do you recall in conversations with Andrea if we did include anyone?
Yeah, we did not formally as a group reach out to participants, but what we tried to do very carefully was craft a group and then bring to, thank you. I don't know if everyone could hear me. As a group, we could not in this process formally reach out to participants and bring their voices in as much as they were or were not at some of the meetings where this was presented. I will say that I know that individually work group members took it to community advisory boards, they took it to lab group meetings where community researchers were present, talked about it and brought feedback. back to the group. And as someone who, I worked on the race and ethnicity section with Dr. Jennifer Manley, and certainly one of our main goals was to bring our own experiences with talking pretty in depth with participants about these kinds of language issues to the conversation. So I hope that participant voices, community voices are present in the recommendations, but there was not the formal process that you might hope, and that's a great step for next time when we're revising. Thank you for the question.
That would be a really good next step as these get developed. Sorry. You know, in thinking of, and I think that would be a really important step for us to take where we draft these guidelines and we seek the feedback, but it might be the kind of thing where we do some qualitative research and seek feedback from the communities that we're trying to represent by bringing their own voices and make sure that they're heard and reflected as we iterate and develop these over time. I think this is a fantastic step, and I think that there's a lot more that we can continue to do from here.
Thank you, Justin. Continued employment for us.
I have,
All
a,
right.
I have a microphone, Ganesh, and now
Yeah.
I have it, and no one will take it away. I do want to say really briefly, hopefully one mitigating factor here is that actually in the long text that Dr. Babulal was describing earlier, we do recommend as a guideline for researchers, you should be asking participants what they would like to be referred to, not just when you're giving talks and things, but when you are writing about the research. So we're actually telling researchers you need to be asking. It's not an excuse to say, you know, we don't know, or they said this, or this is what the science says we should do. Okay, now I'll give it up.
Good morning. May I make a comment? Good morning, everybody. I'm Dr. Joyce Salisbury, or Joy. Thank you, Ganesh, so much for this talk. And Megan, thank you so much for being a part of this leadership team. And to my colleague way down there, I agree with you. I think that there was a misstep. And y'all know I'm blunt. So anytime I see a list of my amazing colleagues with PhDs and MDs and PharmDs, and we're talking about communities in which we represent, and they are not invited to the table, then we had a misstep. And if we want to really use the principles of community engaged research and CBPR and CPPR and all of these wonderful acronyms, then we have to own it. And so in owning it, that means also saying to our colleagues that are editors, if we don't put the racial categories or ethnic or national or nationality categories in the boxes that the journals say, that we are going to write our demographic characteristics in the way the community members want them to be listed. And we have to own that as well. The other piece, I do think that perhaps there needs to be a caveat added that the community, how the community voice was included, but I think that the next time needs to be now. I don't think the next time needs to wait, because if the next time waits, then we are doing helicopter research, and then we're putting people in boxes in which they may not see themselves fitting. And I will say that my brother up in the front has done an amazing job in my hometown of making sure that the voices of the diverse community here has a say in how we move things forward within our ADRC and our institutions. So I applaud that, my friend. But we do need to do more, and we have community members in this room. And so if we want their voices, then now's the time to talk to them. So, and maybe an addendum can be written.
And maybe you'd like to volunteer to help, Joy?
I got your back. I got your back, brother.
All right.
All right.
Does someone else have one? Because I already asked one. I don't want to hog it. Okay. I was curious about someone, I don't think you talked about the LGBTQIA, but also there's a new NIH designated people with disabilities as a group that needs attention. And I came to ADRD from a focus on aphasia and stroke and then primary progressive aphasia, and then came to this world. And they are not involved in this research at all. So is that on the radar?
A fantastic question. So in terms of, the NIH has recognized those with disabilities, and it's taken them way too long to do that, but I'm happy that the day's finally come. But in thinking about individuals with aphasia, PPA, for those that are not able to actually vocalize, how we can include them. And so I think that would be another step for us in terms of advancing this based on comments and feedback from Justin and Joy in terms of including the voices of the participant, but then also including those that can't communicate. So it's a great point. Thank you. And we have a volunteer. I love it. Thank you. All right, I actually took the entire half an hour, but we've got time built in. Thank you very much.
Allison Lindauer reminded me that I've been negligent. If you ask a question, and please do, please also give your name and where you are from. And the person responding to the question, it would help if you could just sort of reframe the question so everyone knows what we're talking about. All right, so now we're going to have Jason Flatt present. He's an assistant professor in the School of Public Health at the University of Nevada, Las Vegas. He has his MPH degree from the University of South Carolina and his doctoral degree in behavioral and community health from University of Pittsburgh. His research involves issues of gender identity, as well as research interests persons living with dementia who are LGBTQIA, as well as their caregivers. So, Jason?
Me. Well, thanks so much for having me today. And so I'm Jason Flatt, and I use he and they as my pronouns. And so I'm really excited and thrilled that we're going to be thinking about the LGBTQIA+ community. And so let's get into some language that we've incorporated into the language guide. So I'm going to start off kind of framing this in terms of how the NIH is framing it, in terms of sexual and gender minority. And so I use this term, but much like we said in these discussions, we need to use the language that communities use. So when I'm working with the community, I never refer to sexual and gender minority or use the acronym SGM. But this is sort of how NIH is using this to designate the community as a health disparities population. So when I say sexual minority, this represents individuals who identify their sexual orientation as something other than heterosexual. So this could include a person that self-identifies as asexual, bisexual, gay, lesbian, queer, or they use a different term. We also think about gender minority communities. And so it's important to note that these are two separate concepts. So you could be a sexual minority or a gender minority, or you could be both. So a gender minority, this represents an individual who self-identifies their gender identity as not with what the sex was assigned to them at birth. So this could include transgender people, people that identify as non-binary. Myself, I identify as non-binary, and that's why I use the they, them pronoun. It also includes someone that may use another term to refer to their gender identity or expression. And we often see groups are stigmatized because of sort of the social and cultural expectations assigned to a person based on their sex at birth. This also includes a community, represents about 2% of the population, intersex people, or people that are born with differences in their sex development. So this represents individuals who may have differences in how their body responds to their sex hormones. They may have differences in their reproductive anatomy, or even how their body, right, their genetics. So it's important that we think about this. These people are born with these sex differences, but we are including them in the gender minority category. You may hear the term cisgender as well, and this reflects people who their gender identity or expression aligns with the sex assigned to them at birth. It's important to note, and when we're thinking about asking about identities, that sexual orientation and gender identity can evolve over the life course, and so we may need to ask these questions again. So I had already mentioned about the NIH. It was when the National Institute for Minority Health Disparities and the ARC, they came together in 2016 to designate sexual and gender minority populations as a health disparities population. And so it's really important for our community that we can now see greater attention towards research and ensuring inclusion of LGBTQIA+ populations. So I show here just an example. I'm not going to go through all these terms, but as you've heard from others, language is evolving. And so even this, what I'm showing you today, does not represent sort of the diversity of the LGBTQIA+ population. And we also have to be knowledgeable of language changes over time based on historical and social and cultural aspects to the community. And so some language we may not endorse with our community. So an example, transsexual is an outdated term that we often do not use to refer to the transgender community. But there are still community members who endorse this language. And so as you've heard from Ganesh, right, and others, we need to use the language that people use to self-identify with. And so we need to be really humble and open to learning and putting forward the language that people use to self-describe themselves when we're doing research with communities. I love this image, the gender unicorn. It comes from the Trans Educational Student Resources. And what this image reflects is really that gender identity, gender expression, sex assigned at birth, but also sexual orientation, if we think about it in terms of physical or emotional attraction. You see all of these on a continuum, right? And so we do have the trouble of we want to put people into clear boxes, how we identify them in our demographics, but really people's identities are diverse and they may range, right, on this continuum, especially when we're thinking about LGBTQIA+ populations. And I also love to show this wordle or word cloud of sort of represents just the diversity of terms that people may use to describe their gender identity. This language is evolving as we continue to see future generations endorsing new language, and so we have to be open to learning this, and again, putting the language that they use at the center of the work that we're doing. So I really encourage you, and I'm grateful that you're here today and giving me an opportunity to talk and ask you to be open to learning about this language. So why should we be thinking about LGBTQIA+ populations, and why did NIH designate them as a health disparities population? Well, we're seeing with the great aging of the baby boomer generation that there's a growing number of older people that are identifying as LGBTQIA+. These numbers are likely not correct because of the underrepresentation of the community. We estimate that it's close to 3 million people that are 50 and older, and more than 1 million of them are 65 and older. The community is also very diverse. So we know at least 1 in 5 identify as a person of color. And this community faces economic challenges. So 1/3 or more of LGBTQIA+ older people are living at or below the 200% federal poverty level. We also know that the community has not had the same opportunities over their lifetime in terms of inclusion and protection, as well as when they access health care. And so these are huge concerns when we think about discrimination or reluctance to participate in research. So things like stigma, discrimination, but also trauma from accessing mental health care, but also basic health care. We see health disparities among the LGBTQIA+ community, and many of these, when we're thinking about our Alzheimer's research, are risk factors. So we see things like poor health, greater risks or diagnosis of depression, and many LGBTQIA+ people living with a disability. We see that the challenges also intersect with people's race and ethnicity and their cultural backgrounds, so it's important that we acknowledge that. With much of the historical factors, we know that the community has not had the same access to things like marriage equality or protections around adoption or having children. So they're less likely to have some of the traditional supports that we think about as people age, or if they need support if they have Alzheimer's disease or a related dementia. There's a huge challenge in the research that we're doing that requires dyads or a proxy when you're having someone come to your ADRC. At least 2 to 3 times the number of people who are in the LGBTQIA+ community live alone and do not have someone that they can rely on as a proxy or a caregiver. And if they are fortunate to have a caregiver, it's usually one person, and there's very little support, and most of the services in our aging kind of and social service program are not very welcoming to LGBTQIA+ people, as well as the unique issues around historical and current challenges economically to access healthcare, with Alzheimer's disease being the most expensive disease for care. We're seeing right now, when we think about what's happening across our country, an increase in violence against transgender people, as well as the passage of laws that are restricting the rights for them to access gender-affirming care, or even just healthcare providers being afraid about the legal implications of providing gender-affirming care to them. So major issues. When we think about some of the cornerstones of successful aging, these are major challenges for LGBTQIA+ older people. They've faced a lifetime of discrimination and a lack of legal and social recognition. So things like protection for jobs, marriage equality, right? Housing protection. These are all ways, one, to protect wealth, but also to ensure that people can have good health over their life. And these have not been protections that many LGBTQIA+ older people have enjoyed. We also know that healthcare still is not very welcoming for our diverse communities, and especially so for LGBTQIA+ people, whether you'd be misgendered, or they're asking, you know, it might be a microaggression, or I think of it as just an aggression, of referring to, you know, maybe who's this with you? Is this your spouse? Or making assumptions about your gender identity or your sexual orientation, or just being uncomfortable when those questions are asked. We've seen historically a lot of pieces that have impacted the ability for health, and it's really important that we think about intersectionality in this work around things like race, SGM status, and if you're a person of color, but also if you're living with HIV or aging with a disability. And so it's important that we think about all these pieces as they impact the community. So I want to give a shout out to some of the work that's happening with the UDS version 4 and also with the NAC, and you're going to hear from 2 of our colleagues today, Dr. Megan Zulsdorf and Dr. Shana Stites, who have been doing some work around sort of the social determinants module, but also the implementation into this with the UDS version 4. So here today, I just want to give a shout out to some of the measures that are in here. We give sort of a little script to help. There's been some concern around people that would administer this question that maybe your participants would be offended by this, or maybe someone would be uncomfortable with asking questions around sexual orientation, sex assigned at birth, and gender identity. I will say that we have not heard at all that people are offended when you ask about their identities. And so I think there's a little anticipation that this will happen, but so far we have not heard that this is a problem. So the first question I'm starting with is about sexual orientation. We recommend that you allow people to select all the options that would apply to them. So not putting people into a single box and allowing them to have multiple identities, right? So here we have the options of lesbian or gay, straight, heterosexual, bisexual. We include two-spirit identity. This is for our indigenous communities, American Indian and Alaska Native populations. We do recommend that this question is only asked of people from those backgrounds. This is a spiritual term, and we do not want to misclassify someone or use language that is sacred among our indigenous populations. So we recommend that. You'll also see we allow a write-in option for people that use a different term. We're really pushing to not using another or other, right? And allowing it to be a more inclusive, open-ended option. We also recommend using a two-step method when you ask about sex assigned at birth and gender identity, where we ask about the sex that was assigned to you on your birth certificate. You will see right now that the only options we're recommending are male and female, even though people are born intersex. We want to include this in the future, but right now, most states on birth certificates did not give the option of an intersex identity at birth. You'll see again, we recommend a select all that apply for gender identity. I'll show you in a moment how this will work. I want to point out again that the two-spirit identity can refer to sexual orientation and or gender identity. And so again, we want to honor that option of only asking it among people from indigenous backgrounds. So here I show you the first example. This would be how the two-step method works. So you see here with the lines, right? This represents a person that would be identified as cisgender. So here their sex assigned at birth aligns with the gender identity that they endorse. The next option shows you how we might capture a gender diverse person, possibly a transgender woman. And so you see in these options, right, sex assigned at birth was male, and then this participant could endorse one or more of the following options: woman, transgender woman, non-binary, genderqueer, two-spirit, or they use a different term. So this would potentially reflect a gender minority person. The simplest approach we often see in our research, and especially among our transgender community, is that they may not endorse a transgender identity. And so here is another way to reflect a transgender woman. I also want to point out, you will see differences in the language, right? We use male and female when we talk about sex, and we use man, woman when we're referring to gender identity, as well as the other terms. Finally, I'm super proud that we have been able to get intersex traits in our module. And so here, to ensure that this 2% of the population, we actually are seeing research around concerns with cognitive impairment, things like subjective cognitive decline, and some objective work from the UK showing that there are some concerns around cognition from the UK Biobank data. And so we think it's really important that we include this. And so this is the recommended question based on some of the best practices in research. So that is the end of my slides. I'm open to any questions. And again, just thank you for the opportunity to let me talk about this and ensure that LGBTQIA+ people are included in the research we're doing.
Thank you so much. Allison Lindauer, Oregon Health and Science. Could you talk for a minute about RISE? I use RISE in my caregiving research to recruit sexual and gender minorities to my national caregiving study, and I very much appreciate your and the team's efforts about RISE.
Yeah, thank you for the shout out for the work. So the RISE registry, it represents Research Inclusion Supports Equity, is the first NIA-funded research registry for LGBTQIA+ people that may be experiencing memory loss, Alzheimer's disease, or are a caregiver of someone experiencing memory loss. And so it's a registry that's open to other researchers if you want to ensure either in your region to recruit people who identify as LGBTQIA+ for your studies, as well as we've coordinated resources across the country. So it's also meant to be a resource to connect people to local resources in their community to support caregivers or people experiencing memory loss or Alzheimer's. So it's the riseregistry.org, and you can access it. So thank you for that shout out about it. Thanks.